Good morning, everybody. Early here, that's good. Uh, that's right. That's right. That's right. Well, thank you much for coming. I hope a lot of people are online too, or maybe get the chance to do it later. Um, Over the last couple of weeks, I was asked a couple of times to introduce the overall congenital program, although I think that would be up to Chuck at some point to do, and I think we're going to repeat it. But when we were asked to present our collaboration, I asked Rod to come in and talk about, just in general, the options that we have in transcatheter solutions for congenital or young adults with congenital heart disease. What it really highlights, and everybody can read Rod's bio. I don't want to spend too much. I think most of it is Midwest and then San Diego for intervention cardiology, and the combination of those two is very special, obviously. But I think what's special about the collaboration is really the amazing connection that we have with children's just through a skyway, or I don't know if you can even go through a tunnel. And so that is very unique in the whole nation, maybe even, internationally. And I think the collaboration between the two of us, for example, highlights how well this can be done. And we both hope that on an even higher level that continues and will go further than it is right now. So I'm really happy to introduce Rios from Children's. A nice collaboration that we have on an interventional side of things, and I think everybody's going to learn a lot about the options that we have in interventional cardiology.
Thank you. All righty. Thank you. Thanks, Dr. Gessel, and good morning, everyone, and thanks for inviting me. Happy to be here, and I've met some of you, and I hope to meet more of you. And when Dr. Gessel and the team, initially asked me to give this talk, the topic that was presented was children with heart disease, which it turns out is our whole specialty across the street. So I can't give you a kind of a concise overview of that, but I can talk about kind of what I like the most about pediatric cardiology, which is our transcatheter interventions. And we can use that as a framework to talk about a lot of the different congenital heart diseases that we treat across the street. And for your group to keep in mind that a lot of these patients, as you'll see, are surviving long enough to see you here in an adult institution, and how important that's going to be, moving forward, because that wasn't always the case. So as you likely know, congenital heart disease is the most common congenital disorder. It affects 1 to 2% of the population, so some job security for me, but 10% of those are quite complex and 30% are fairly complex, and about 25% will need some kind of intervention in the first year of life, be it in the cath lab or surgery. And again, the important highlighted point on this slide for you guys is that the majority are surviving into adulthood, even those with the more severe or complex congenital heart diseases, compared to the 80s of many, many more of those patients are surviving, to the point where there's now more adults with congenital heart disease than there are kids. So super important field that is kind of in its infancy and is going to need a lot of support going forward. This is our cath lab across the street. It's a biplane lab. In the congenital world, we often use a biplane, which is one difference from some of the adult interventions, but we only have one lab across the street, and it's, to tell you the truth, it's on its last legs. We're going to get a new lab here in a couple months. When I come over here and see 9 cath labs, I get quite jealous. So, and it's myself and Dr. Vesmar are the 2 interventional cardiologists across the street. So 2 of us, we do about 350 to 400 cases a year in the cath lab, and that puts us at kind of a medium-sized program. And we do about the same amount of surgeries. Our surgeons, we have 3 cardiothoracic surgeons. They do about 400 to 500, pump cases a year, which again, that's kind of a medium-sized program, which is appropriate for the metro area here. I wanted to start with these patients because it gives you a nice scope of what we do across the street, a nice range of patients. These are premature infants. You can see there's a Mr. Potato Head for scale. They're quite small. And in general, the situation we're meeting these patients in is with a pain ductus arteriosus. These patients are born very premature with premature lungs with very significant lung disease. And as you know, all babies in utero have a PDA or patent ductus arteriosus, and in the vast majority of term infants, that closes in the first few days of life. But in these premature infants, it often stays open. And because of their very severe premature lungs, that extra pulmonary blood flow is not well tolerated, and it can give the neonatologist taking care of them quite a lot of challenge as far as weaning their respiratory support. So that's when we meet them, and traditionally, the only option for patients this small was surgery, or a cardiothoracic surgeon, or in some cases, a general surgeon in some institutions would do a PDA ligation through a lateral thoracotomy. And it's still a good option and fairly well tolerated, but it is fairly invasive and does have a pretty significant inflammatory response that sometimes is challenging for the neonatologist. This is these two are twins that we met. This isn't their X-ray. This is a different X-ray, but this is an X-ray of a 900-gram, very premature infant, so less than a kilo. And you can see they're not even intubated, but the team was having quite a bit of difficulty weaning the respiratory support. So luckily for us, in 2019, Ann Platzer developed this tiny device called a piccolo occluder, and it's a PDA device specifically designed for those very small premature neonates. So actually FDA approved for 700 grams and higher. So about less than what your pair of shoes weigh is what they weigh. Sometimes I walk into the cath lab and look at the table, and I don't even know if there's a patient there or not because they're so small. And the good thing about this device, there's a lot of good things, but it's similar to other devices that we've already had. We've had ductal occluders for bigger patients for years and years, and it's similar. It's made of a nitinol mesh, which is a nickel and titanium alloy. But the good thing about it for these patients is it goes through a very small sheath. So a 4 French sheath and a 4 French catheter is all we need to introduce this device into these tiny premature infants and close the PDA that way. You can see this picture as a lateral from the side, and that this is a hand injection in this extra blood vessel, the PDA. So the aorta is in the back, the PAs are in the front. We often keep this temperature probe here because it really lets us know where the aorta is. We do this both with fluoroscopy and with echo at the same time, just transthoracic echo. And we can deploy this little device in the PDA and close it. So much less invasive than surgery, and very well tolerated. They don't have that inflammatory response, and they recover very quickly. And typically the neonatologists are able to move them along quite fast afterwards. You could see the difference in the X-ray. Of course, now they're intubated and probably better ventilated, but it is a pretty fast response as far as just taking away that little bit of extra blood flow to those premature lungs. So those are the smallest patients we take care of. The smallest we've done across the street is about 880 grams, so less than a kilo. So that's the smallest. And then we take care of adolescents that can be well over 100 kilos. So our tiny premature babies to obese adolescents and young adults. Moving on to single ventricle heart disease, these are some of our most fragile patients, so worth talking about. And you'll see in the coming slides that the cath procedures and the surgery program really go together. So all complex patients with congenital heart disease that have surgery, many of those will require both diagnostic and interventional caths, and that's what you'll see in the coming slides. But about 8% of those with congenital heart disease have single ventricle heart disease, so plenty of patients. And the good thing is that despite, as you'll see, there not being much improvement in the mortality early on, if they do make it after a year, then the vast majority of those are living to adulthood, which I'm sure some of you have seen here, patients with Fontan circulation, and those patients can be quite complex and require a lot of resources to keep them as healthy as they can be. So if you look at these examples of different types of single ventricle anatomy, which again, there's many more than what's on this slide, but these are just 3 examples just to get a sense of what the physiology and the anatomy can be. It can be very different, and it really depends on the individual anatomy as far as what you'll see from a physiology standpoint. So if you look at the picture with hypoplastic left heart syndrome, when these babies are born, they're dependent on the extra blood vessel, the PDA, or the patent ductus arteriosus for systemic blood flow. So as is appropriate for the name, everything on the left side is small, right? A severely hypoplastic mitral valve, severely hypoplastic left ventricle, a very small, sometimes very tiny ascending aorta, maybe a millimeter. It could be smaller than the coronary arteries themselves. And then the aortic arch is very small. So again, these babies are dependent initially on this ductus. If they're born at home or in the Amazon rainforest or something, and that PDA closes, then they pass away from cardiogenic shock. So when they're born here, the vast majority now are diagnosed prenatally, and as soon as they're born, they're started on prostaglandin to keep that open in the setting, again, of ductal-dependent systemic blood flow. If you look at these two other examples, they're not in that situation. Specifically how these pictures are, there's a single ventricle, but there's no obstruction to outflow to either the lungs or the body from the aorta. So these patients, when they're born, they don't have ductal dependent circulation, and they may look fairly healthy, maybe a little bit cyanotic, but otherwise, what happens is as the pulmonary vascular resistance decreases in the first few days to few weeks, if it's like this picture shows, without pulmonary stenosis or any kind of subpulmonary outflow tract obstruction, they'll develop pretty quickly signs of pulmonary overcirculation. As the pulmonary vascular resistance decreases, their systemic saturations will go up, and their cardiac output will go down, and they can have what we call, in this setting, heart failure from pulmonary overcirculation. So different challenges despite both being single ventricle heart diseases. So they both require they can require early palliation. In the setting of hypoplastic left heart syndrome, they always require an early palliation. In these other entities, it depends on how balanced the circulation is. If they have some degree of pulmonary stenosis, that can be a good thing in this situation, because if their saturations, their systemic saturations are, let's say, 70s to 80s, and they have a pretty well-balanced circulation, we can kick the can down the road a little bit for surgery and let them have some time for growth and development prior to surgery. So all under the umbrella of single ventricle heart disease, but it can be quite different physiology. As far as the hypoplastic left heart syndrome, like I said, these patients all require fairly early palliation. The most common would be a Norwood procedure. So that's when the surgeon, a very skilled surgeon, combines the pulmonary artery with the native ascending aorta and makes this neo-aorta. So not pictured here in the back would be the native ascending aorta. This is the neo-aorta. And then we need to have some reliable way to have pulmonary blood flow. And the way they do that is either with a BT shunt, which I'll show you examples of, or a Sano shunt, a right ventricle to pulmonary artery conduit. So these two types of Norwoods are, the vast majority of the palliations that hypoplastic left heart syndrome patients are getting, typically within the first week of life. Sometimes they're not very good candidates for that surgery. That's a big surgery. Like I said, sometimes the ascending aorta is 1 millimeter. So you have a very skilled surgeon working on that heart, and you're talking about differences in 1 millimeter, 2 millimeters can kind of be a make or break situation if the patient will survive or not. And sometimes if the baby is premature or sick in other ways, maybe they have a genetic syndrome or maybe other comorbidities, they're not a good candidate for a Norwood operation that early in life. And that's what you see on the right here is another option called a hybrid procedure. And you can see by this picture that involves both a surgery intervention and a transcatheter intervention. So instead of making this neo-aorta, there's a stent in the ductal arch to keep that open off of prostaglandin infusion. If there's any restriction at the atrial level, there'll be a stent there. We can stent that open. And then there's pulmonary artery bands to decrease the amount of pulmonary blood flow. If you do this procedure and don't put the bands in with normalizing pulmonary vascular resistance, you'll get too much blood to the lungs, so your QP will be very high and your QS will be low, and you'll have poor cardiac output and they won't survive. When we look at these three palliations, the vast majority of centers in the country and the world kind of reserve the hybrid procedure for those patients that aren't great candidates for Norwoods. So with that selection bias, the mortality in the hybrid procedure is quite higher. There are some exceptions. There are centers that do more hybrids, like Michigan and Cincinnati, but that's, again, the exception, and the majority of the centers will be doing one of these two options initially. And something that's I've kind of found a little bit disheartening since the time I've started, fellowship 12 years ago or so, and looked at older papers and now these more modern papers, is the mortality as far as Norwood procedure and the early mortality really hasn't improved much. It hasn't changed much, and it's actually fairly high. If you look at this nice paper that came out from the NPC-QIC, which is a collaborative of many centers that do, I think 69 centers that do Norwood cases, you can see that as you would expect, the mortality is correlated with the volume of your center. So if your surgeons are doing more Norwoods, their mortality is slightly better, and vice versa. But even in the high volume centers, which are over 10 Norwoods a year, the mortality is still pretty high, like 15% or so in that first year of life. So these are by far one of our most, or the most fragile patients we have is in this kind of single ventricle first stage palliation, and that's for multiple reasons, but you can kind of get a sense from the anatomy. They're very dependent on having pulmonary blood flow that was created surgically. Our center is in this medium volume category, but I'm happy to say that our mortality is more closer to the higher volume centers, and that it varies year to year, but it's typically kind of around that. So fairly high mortality in that first year of life. And because of that, we concentrate a lot on things that we can do to improve that at our center. So we have a clinic and a group dedicated to single ventricle heart disease. So a single ventricle heart disease team, which I'm lucky to be a part of, and two of my partners, and then three of our nurse practitioners, and they do an amazing job concentrating on this group. One thing that helps the mortality in this population is having a monitoring team, a home monitoring team. So our nurse practitioners have a dedicated iPhone or smartphone, and all the patients that have a child that has undergone stage 1 palliation have access to that, so 24/7. And every day they have an app on a tablet where they log things like feeding regimen, weight gain, oxygen saturations, and really we try our best to keep them as healthy as we can and not miss anything before it becomes a big problem because they're so fragile. And that's been shown many times to improve the mortality having a home monitoring program like that, and it's certainly true at our center as well. We don't have to go over this slide in detail, but there's other centers and the same collaborative has tried to come up with scoring systems to try and predict mortality in these fragile patients. And you can see what we look for kind of makes sense as far as what increases the mortality. In the Norwood type, in the early Norwood, the BT shunt has slightly higher mortality than the Sano shunt. If you've needed ECMO or opiates, and then most importantly, if you have any AV valve regurgitation, that's a big deal for single ventricle heart disease. And being on oxygen really increases your risk. So if you can see, if you rack up these points compared to if you don't, your mortality is predicted quite a bit higher, 16% in that interstage time period. If you're interested in the origin story of the BT shunt, there is a nice movie. I think it's on HBO. If you run out of other things to stream from all the streaming services on your board, you can watch this movie, Something the Lord Made, and it's a movie about the first time they did a BT shunt in the 1940s with Dr. Blaylock and his assistant, and then the cardiologist, and a nice kind of movie about that with starring Alan Rickman. This is an example of a BT shunt, and again, this is where you'll see how close surgeons and us in the cath lab have to work with these patients. But again, a BT shunt or a Blaylock-Tau-St. Thomas shunt, it should be a BTT shunt, is basically a Gore-Tex tube that the surgeons connect from the innominate artery to the pulmonary arteries, and that's true in the setting of many types of congenital heart disease. Basically, anything where the newborn or infant needs extra pulmonary blood flow. It can be in those single ventricle heart diseases like we saw the pictures of, or it could be in biventricular hearts, like a patient with tetralogy of Fallot that doesn't have enough pulmonary blood flow initially in the immediate newborn period. In this particular patient on the right, this is just a still picture, but if it was a movie, it would look pretty similar. You can see the innominate artery here, and you can see a nub of something there, and that's where the BT shunt is. And this patient has ECMO cannulas because of this, because the shunt is occluded. So this patient didn't have any other source of pulmonary blood flow, and in the fairly immediate post-operative period had some kind of cardiorespiratory arrest. They became desaturated, CPR was initiated, they were put on ECMO, and the reason for that is that the shunt became occluded. So in that situation, the two options are basically going back to the operating room and revising the shunt, or we can take him to the cath lab and see if we can open it. Oh, and that's what we've done here, and that's what we typically do in those situations. So you see the BT shunt's occluded, and then afterwards we've stented it nice and wide open. And one thing that you may notice on the coming slides too is that many of the things we use in the pediatric congenital cath lab aren't made for us. We basically find anything we can off the shelf that can help these patients because there's very few devices that were made for us, and that is improving as we started with that Piccolo device, for example, that's made for us, but many of the things we use aren't. So this stent is actually a coronary stent, so an adult coronary stent that you guys use every day, many, many times here. We have those on our shelves just for this reason. So this is a 4mm drug-eluting coronary stent, same kind you have here, and we use it to open this BT shunt up, and you can see it works really, really well for this. It almost looks like it was designed for it. It takes the shape of it, the same size. These shunts are typically 3.5 to 4mm when put in. So these 4mm coronary shunts work really, really well to open that up. And it really gets us out of a bind in many times because it's a big deal to go back to the operating room and revise that shunt. If you remember the hybrid approach that I showed you before, the picture of the hybrid, there is now a way to make that same physiology all in the cath lab without any kind of surgery. This is a technique that was developed in Germany. A few years ago this was published, and it kind of has caught on, and more people have been doing it. Again, if we're at our center and at most centers, if we're talking about a hybrid approach, that usually means there's something not ideal with the patient. They're not a very good candidate. So you have to keep that in mind as far as outcomes of those procedures. But when we do have a poor candidate for a Norwood or some kind of surgical palliation, we do now have at least a technique where we try to limit pulmonary blood flow, and that's what you're seeing in this picture. So again, something not made for us at all. This is a Medtronic microvascular plug. It's made for the periphery, for peripheral interventionalists to put in other areas, adults to put in other areas of the body. Can't tell you really what they use it for in the adult world, but it's a lot of peripheral, it's a peripheral occlusion device. But we take this device and modify it, and we use this lacrimal duct cautery tool, which is the only time I get to use cautery in the cath lab, which is pretty fun. We use this tiny cautery tool and make this tiny hole, and then we can put these devices into the pulmonary artery. As you see here, this patient with, again, hypoplastic left heart syndrome. So if you don't do anything, in the first few days to weeks of life, they have more and more pulmonary circulation, so really high QPQS, and they don't do well. Because of that. They again develop what we call heart failure or perfusion and can pass away pretty quickly. So we can put a tiny hole in these devices and put them in the branch pulmonary arteries, and they act like PA bands. They act to restrict the pulmonary blood flow. So we call these pulmonary flow restrictors. What's not pictured in this diagram and what they did in Germany when they do this is they also put a ductal stent here. They put a stent to keep this open, so now the patient doesn't have to be on prostaglandin infusion. Now that all sounds really great, but there are some drawbacks to that. It is a pretty fragile circulation. For example, let's say you have aortic atresia, so your native aortic valve doesn't open, and the only way you're getting coronary blood flow is retrograde flow, right, in the transverse aortic arch down into the ascending aorta. That's the only way you're getting coronary blood flow. and now you're going to be putting a stent here, right? They're jailing the only source of coronary blood flow. So this is a very, again, fragile situation. It doesn't always work out the way you want it. You can get a reverse coarctation, and that patient can have ischemia and pass away. So when we've done this at our center, we don't put the ductal stent in, mainly for that reason, and I'll show you an example of that. But we don't always, our community isn't always good at kind of tracking new techniques, but I think we're getting better, and we're in our cath lab across the street, part of 3 different registries, and this is one of them. And one of the things that we're keeping track of is this PFR procedure, but the hope that someone in industry will make us a device specifically for this. That would be our hope, because in modifying these things and using them is kind of the best we can do, but it's really not meant for that, and it's not ideal. Despite putting a really tiny hole in, many times you still have too much pulmonary blood flow. So a specifically designed device for this would be really nice for us. So if we can track it and show that it works, potentially we'll have some more support from industry from that standpoint. This is one example that we did across the street. So this was a 6-day-old and an only 2-kilo patient. And if you remember, I'll keep going back to how difficult these surgeries are. In a 2-kilo patient with hypoplastic left heart syndrome, that ascending aorta that needs to be reconstructed is going to be very, very small. The next time you see a newborn baby or a premature baby, I like to just remember, look at their fist. Their heart's the size of their fist. Their fist is very, very small. And a surgeon has to do all this complex congenital heart surgery on that very, very, very small heart. So just being 2 kilos is enough of a, risk factor that you maybe don't want to rush into a Norwood. And usually if you're 2 kilos, that means something else happened, right? You're born premature, or you have intrauterine growth restriction, or maybe you're syndromic. But these patients are quite small. And again, they're born, and typically their saturations are, let's say, 70s, 80s, but as that pulmonary vascular resistance decreases, then pretty quickly, even within the first couple days of life, those oxygen saturations can be in the high 90s systemically, and then your venous saturations concurrently will be quite low. Your AVO2 gradient will be wide. You'll have things like poor urinary output, neck, signs of poor systemic perfusion. So if you don't do something, those babies aren't surviving very long. So either you can do a Norwood or a surgical hybrid like I showed, or you can do this new technique. And that's what you see here, those same microvascular plugs. That's what they look like on fluoro and x-ray. So both of these devices have a little hole that's helping to restrict pulmonary blood flow. So typically when we put these in, we're wanting to see saturations, in the 70s in the cath lab on room air before we leave the cath lab. And we also look at echo, transthoracic echo, to see kind of what gradients we're getting. But really the saturations are the most important, thing. We want to see that we're kind of, that these pulmonary flow restrictors are doing what they're supposed to. And the challenge is that many times they work, but not enough. There's still, over time, I don't know if the covering maybe, peels away or just changes, but they do tend to get over circulated even with these. Sometimes other centers have kind of replaced them in those situations. But the goal is to just buy them some time and really just getting them out of that immediate neonatal period, getting them a bit bigger. And this same patient underwent a Norwood with a Sano shunt at 2.5 kilos, so not a whole lot bigger, but 5 weeks later. So some time for just somatic growth, somatic development, brain development, get them out a little bit more before they have a huge surgery. So I had the Norwood Sano at 2.5 kilos and 5 weeks old, did quite well. And then around 4 months of age, once we were planning the next stage, which I'll show, the Glenn palliation, started having less some oxygen desaturation, not doing as well. On the CT, the Sano shunt, that's what you see here. This is a picture from the side. And so this is the right ventricular outflow tract, and this is the Sano shunt. And you can see it's quite narrow proximally. So again, we use stents that aren't designed for this to open those areas up and buy them some more time before surgery. These stents are renal artery stents, formula 418. Their open cell bare metal stents, and they work really, really well for this and for many other applications. So we're lucky to have these stents that aren't designed for us, but work quite well. This is a very interesting anatomy to talk about as well. So this is a pulmonary atresia with intact ventricular septum, which can be a single ventricle heart disease or a biventricular heart disease, depending on the details. So the first kind of question is, how big is the right ventricle? How big is the tricuspid valve? If the tricuspid valve is big enough and the right ventricle is big enough to support pulmonary blood flow, then sometimes the first intervention can be in the cath lab. We can use radio frequency perforation, and we can open this pulmonary valve. So again, this patient was born with a atretic pulmonary valve, so it doesn't open. So if the right heart is adequate enough to support pulmonary blood flow, we can take him to the cath lab in the first few days of life and perforate this valve and balloon it, and see if we can kind of buy them time as far as having adequate pulmonary blood flow without a well-functioning valve, but get them bigger to either have more cath interventions or more surgical intervention. The other side of that is if the right ventricle and tricuspid valve are quite small, that puts you in another category. That's more of a single ventricle category. And then there's another very important question when we see that, and that's what's going on with the coronary arteries. There's an entity called pulmonary atresia with intact ventricular septum, so PAIVS, with RVDCC, or right ventricular dependent coronary circulation. And that's what this example is. So this patient, again, very hypoplastic right ventricle, and we look at, and what we do in all these patients is assess the coronaries, and that's what you're seeing here in aortogram. So this is a straight frontal projection, so from the front. Catheter is in the artery all the way around the aortic arch, and that's where an ascending aortogram is being taken. And you can see the left coronary artery. You don't see anything on the right side. There's no right coronary artery. And so that clues us in as to what's going on. And when we put a catheter in the very hypoplastic right ventricular chamber, now you see the rest of the coronary arterial vasculature is all coming off of the right ventricle itself. So this is the entity that we term right ventricular dependent coronary circulation, meaning that if you decompress this right ventricle by opening this RVOT, there's a very good possibility that this patient wouldn't survive that, because they would not have adequate coronary circulation at that point, and those patients pass away in that setting. And even without doing that, these patients are very, very fragile, and they have a high mortality. I think about 30% in the first year, and that's because of how fragile and finicky this coronary circulation is. So it's not uncommon for them to have ventricular arrhythmias, a lot of ventricular ectopy. Any kind of bubble in the venous system can result in these patients having like a cardiopulmonary arrest. So they're quite fragile patients, and because of that, the palliation, the initial surgical palliation, which would typically be again a BT shunt, even that surgery is has a very high mortality. I think Dr. Moga says about 3 times of a patient without this. So it's certainly has happened where the patient doesn't even survive that initial palliation. So with that, we can palliate them in the cath lab instead to make it a less invasive initial palliation. And the way we do that is by kind of creating the same physiology as a BT shunt. So instead of a surgical connection between the innominate artery and the arteries that go to the lungs, the pulmonary arteries, we put a stent in the PDA itself. And so that's what this picture will show. This is a catheter or a sheath in the axillary artery of this patient, which again, these are newborn babies. So these can be normal sized newborn babies in the 3 to 4 kilo range or smaller, but if we're lucky, a nice term big sized baby with a sheath in the axillary artery, and that's where we're taking a little hand injection. And you can kind of see in the diagram, this left subclavian is oftentimes right on top of the PDA, or patent ductus arteriosus. And what's different than the diagram is it's often quite difficult to get there from below. That angle makes it quite difficult. But if we get there from the carotid or the left subclavian, it's a nice straight wire course. And we can, again, use our nice coronary stent, put it in the PDA, and now we've palliated the child without having surgery as an initial step. What to do with these babies does vary. Many centers in the setting of PAIVS with RVDCC, the mortality is so high that they'll primarily list these patients for heart transplant. That's not uncommon as a strategy at many centers. We did that with this patient as well. But the thing is, when you list someone for transplant, as you may know, that doesn't mean the next day they get a heart, right? They have to wait. And if you wait long enough with this physiology, eventually you need something else. So even though this patient was listed for transplant, she was stable enough that when she was the appropriate age and weight for the next palliation, we just did that, and she actually never did get a transplant, and she's now a Fontan patient. So, so that's not an uncommon story, but it's really unpredictable when they're first born and you see coronary arteries like that. They're kind of, unfortunately to say, they can be ticking time bombs as far as having some event that they're not going to survive. And even Fontans with this anatomy do have a higher rate of sudden death at home, or arrhythmias or things like that. So they're not out of the woods even then, but they do have a much higher chance of survival if they survive the first few years of life. So that brings us to the next stage, palliation. So once these children with BT shunts or Norwoods, once they're 3 to 5 months of age, they're much bigger. The pulmonary vascular resistance we know has normalized. Then the surgeons and the team recommends the next stage of palliation, which is a more kind of reliable, more robust palliation. So if you look at this diagram in the setting of hypoplastic left heart syndrome, the surgeon takes away the BT shunt or the Sano shunt, depending on what that particular child had, and then connects the SVC to the pulmonary artery, so a caval pulmonary connection. So this is what we term a right-sided bidirectional Glenn. Sometimes there's also an LSVC, that would be a bilateral bidirectional Glenn, but typically this is what we're looking at here. And this is what you see on this angiogram, is you see this is spinning around the patient, and that's one thing that we like to use a lot in our cath lab. Not all congenital cath labs use it, but a good handful of us have really kind of embraced this type of angiography, which you'll see is we call 3D rotation. So it's rotating around the patient, and then it allows us to post-process it in Vitria, which is the same type of software that you use here and that we use across the street for CT. We can take that spin and use it to make this reconstruction. And the nice thing for us is then we can manipulate this all over and kind of look at it from different angles and make sure we're not missing anything. It'd be really hard to miss this, though. So this one, this is the same patient I showed you previously where we stented the PDA, the patient with pulmonary atresia intact septum. You can see on this spin there's leftover stent material, so the surgeon just clips that stent when they don't need it anymore. And that same patient developed pretty severe left pulmonary artery stenosis. So, as you can see on the spin, you see the right pulmonary artery, but you don't see any filling of the left pulmonary artery. So one thing that's very important in both Glenn and, as you'll see, Fontan circulation is everything has to be nice and wide open. There's no pumping chamber pumping blood to the lungs, so it's really dependent on passive pulmonary blood flow. So the pressures, the resistance in the lungs have to be low, and everything has to be nice and wide open. Even a little angiographic narrowing or even a little bit of a pressure gradient can make a big difference clinically. So we're pretty aggressive at opening those vessels up, and you can see that's what we've done here. Again, used a stent that's not designed for this. This is a VisiPro stent, I believe. It's also a peripheral stent, an open cell, bare metal, balloon expandable stent that works really, really well for this application for us. So even, again, not designed for us, but it works really well. It's open cell, so if we did have to jail any of these branch pulmonary arteries, which we do sometimes, oftentimes they still get flow and you're still able to keep them open. The next stage is the Fontan. That's typically done between 3 and 5 years of age for a few reasons. One is they're big enough, they've tolerated Glenn circulation. We know that their pulmonary vascular resistance is adequate to tolerate these palliations, and also they're bigger. So this Fontan procedure, what you see pictured here is an extracardiac Fontan, and that's basically a Gore-Tex tube or conduit that connects the inferior vena cava to, again, the pulmonary arteries. So now all the systemic venous return from above, all the systemic venous return from below, all goes through the glen and through the Fontan to the pulmonary arteries. And so your oxygen saturations in this setting will be significantly higher. The only unoxygenated blood that is now returning to the heart is via the coronary sinus. So the coronary arteries, feed the myocardium. That venous return goes to the coronary sinus, and that desaturated blood is still mixing in the heart, but all the rest of the systemic venous return is going to the lungs first. So typically the oxygen saturations in this setting are going to be in the low to mid 90s. It shouldn't really be 100 because, again, of that coronary sinus desaturated blood. This, again, there's different types of Fontan. This is, I would say, the vast majority of modern centers now are doing extracardiac conduits as opposed to using the atria itself to create the connections as many centers were doing before. And we still see, Dr. Gessel will know, we still see patients that have other types of Fontans here because the practice has evolved. This Fontan does not have a fenestration. Sometimes there is what we call a fenestration, which is a connection between this conduit and the atria. And the practice of putting in a fenestration varies widely from center to center. Some centers put a fenestration in all patients. And what that does is it allows a pop-off. If the pulmonary vascular resistance or the pressures in this circuit are high, it allows a right to left shunting, so a pop-off from the Fontan into the heart. So you're trading, you get a little bit more cyanosis, but you get preserved cardiac output. And our center and many other centers do fenestration selectively. So if a Glenn patient has kind of borderline high pulmonary pressures, borderline pulmonary vascular resistance, they have significant AV valve regurgitation or any other kind of comorbidities that we think are going to put them at higher risk of not tolerating Fontan circulation, those patients will get a fenestration off the bat. Sometimes the fenestrations over time close on their own. Other times we can close them in the cath lab with devices like atrial septal defect occluders. We can close those holes. Typically, that also varies from center to center, but the most common scenario would be an adolescent or a teenager who has a fenestration, when they're active, they have desaturation or cyanosis. We can test occlude the fenestration, and if the physiology tolerates it, we can close it. One of the most important things with this I'll kind of go back, with this physiology is surveillance, because the patients can look, after they recover from the initial Fontan procedure and go home, they can look really, really well, and they can do really well. And the families, patients, we can kind of forget that they still have very severe heart disease. So even though the Fontan, even though the staged palliations and the Fontan is the best we can do currently for these patients, it's not normal, and it's not normal physiology. There's supposed to be a pumping chamber pumping blood to the lungs, and the right ventricle isn't meant to be a systemic, right ventricle. So even though it can be well tolerated and patients can do really well, we always have to remember that it's not normal, and things are eventually, there's a propensity for things to deteriorate over time. So our most important role is surveillance with these children as they become adults and hopefully meet you guys here. To be able to do that, we have to make sure we don't miss anything that can be a big problem. So that's been a real big focus internationally with these patients is surveillance and finding things before they become a problem. Because again, you can have kind of what I would call a honeymoon period where they look like normal, completely normal children. They act like normal children. They are normal, but they have very severe heart disease. So we have, with that, we have at our center and many other centers have a very kind of protocolized surveillance schedule, and we don't follow it to a T, but it kind of gets us in the ballpark as far as what we need to look at. So both obviously echo and EKG, heart rhythm monitors, of course, but we also keep a close eye on the liver. We do check labs and then more advanced images because Even though echo is great and it's a very useful tool, it doesn't show as much detail as you would want in a Fontan, conduit or the branch PA sometimes. So typically we're getting advanced imaging in the form of an MRI or a CT at some point a few years after the Fontan, and then in everyone, 10 years out, a cath to double check everything. And sometimes we've done a cath already based on the echoes or MRIs or things like that. But if you're doing really well and don't have any other issues, at 10 years, we're still going to do a cath to check everything, check your pressures, your pulmonary vascular resistance, and make sure there's nothing that we're missing that we can improve upon. The liver is quite important. That's become evident over the years. If you think about it, the liver drains right, obviously it drains right to the IVC. And in a normal heart, the right atrial pressure, as we know, is about 3 to 5. And if you have a really good Fontan circulation, your pressure in the Fontan is going to be maybe 9 or 10. That's a really, really good Fontan pressure. That's still much higher than what the liver's supposed to see. It's supposed to see 3 to 5. So now we know that affects the liver. And even in early Fontan patients, the liver will be more stiff than normal. If you get, we now get liver ultrasound elastograms to look at the stiffness, and we obviously look at the liver function as well. And early on, these patients have stiffer livers than normal. It doesn't affect the function early on, but the process starts very early on. And this is an area of active research, and honestly, we don't, as a community, we don't have great answers to what to do with all this, but it's at least we're looking at it when our patients do develop liver dysfunction, then we send them to a hepatologist. We think about medications, but the liver is certainly important in the circulation, and particularly in older adolescents and adults as they get here. Many of them can develop liver failure, which is quite a challenging situation. One more thing that's really important with Fontan circulation that's become even more evident in the last 10 years or so is how important exercise is. Exercise is super important for these patients, and that's kind of a little bit of a shift of thinking because, traditionally it's not uncommon for, let's say, a primary care provider or the family to look at a patient and they have a sternotomy, they know they have severe heart disease, and they tell them, you don't have to be active. Go ahead and take it easy and restrict yourself. That's actually the wrong approach. We now know, and that's been shown kind of over and over again in the last 10 years in different studies. But if you think about it, there's no pumping chamber pumping blood to the lungs, so it's really dependent on muscle tone and activity. So the more active these patients are, the better they do. Probably better than any medications we can give these young Fontan patients or these adolescents, teenagers, young adults. The best thing for them is to be very active because that helps that pulmonary blood flow. And it helps, and it in turn helps the cardiac output. So they shouldn't skip leg day at all, the Fontan patients. These are just examples of the surveillance Fontan caths that we do. Again, we use this 3D rotation, which again helps us see all the angles and not miss anything, any stenoses. In these particular angiograms, we're injecting at the same time in the SVC and in the IVC. Example of something, this patient had a stent coming in, so we see that it's narrow, we measure a pressure gradient there, and then we can use a balloon catheter and get it bigger as the patient grows older. Sometimes we see we do surveillance caths, and the echoes look good because the echo is really only showing the gland, maybe the proximal gland, maybe the proximal PAs, but you're really not seeing out into the distal pulmonary arteries. So you can see this left pulmonary artery is quite kind of irregular. And if you look at this anatomy, this is very typical for someone with hypoplastic left heart syndrome. This bend here is actually their native pulmonary artery bifurcation. So what is now the physiologic proximal left pulmonary artery, that used to be the anatomic physiologic right pulmonary artery, and that's a natural bend. And it's not uncommon for them to develop stenoses along this pulmonary artery because of the geometry and the differences in flow kind of dynamics over time. So again, when we see something like that, we can interrogate it with with 3D imaging, we can kind of get a really good sense of where the problem is. We can measure pressure gradients there. And one thing that's really nice about our 3D rotation capabilities is we could also bring in other extracardiac structures like the airway. So that's what this green is here. It's showing us where the left bronchus is, which is a known complication of stenting a left pulmonary artery in a patient with Fontan. The left bronchus can be right behind there. If you're too aggressive and don't think about it, you can compress that, and now you have bigger problems. So this gives us a sense of where we are, and it gives us a sense if we need to be more careful stenting, which is what you're seeing here. Again, this is again a Visipro bare metal stent made for adult peripheral artery disease, and using it to open up that pulmonary artery nicely. This is just another example of that bronchus where it's right at the level of the left pulmonary artery stenosis. And when we see this, we can, depending if we think we have enough room, we can proceed. If we're questioning it, we can bring in a pulmonologist. They can do a bronchoscopy, and we can test it with a balloon. We can inflate the balloon in the left pulmonary artery and look at the bronch and see if we're seeing significant compression and decide whether or not we want to proceed with stenting. If it looks too dangerous, then we can bail and the patient can have a surgery. But again, it's a pretty big deal to have a surgery in these patients. So we try and be fairly aggressive in the cath lab, opening this up. Again, super important in Fontan circulation or Glenn circulation for all these pathways to be nice and wide open, because they're really dependent on passive pulmonary blood flow. I think that's one of the advancements in the coming years. We'll be looking at that in different ways with MRI, for example. I think the imagers here and across the street can do a lot with advanced imaging now. And one thing that some centers are doing is using like 4D MRI, where they're actually looking at the flow dynamics of the blood. I think that'll be in the coming years a very useful tool, because sometimes the pictures don't tell the whole story as far as how the blood is actually circulating through this circulation. This is just an example of all the different metal these patients can end up with. So these are fairly early post-Fontan patients, and you see the IVC stented, the pulmonary artery stented, and there's tons of coils. What can happen with these patients that have kind of borderline Fontan physiology is the body will make lots of extra blood vessels, either to get more blood to the lungs or bypass the lungs. And that can be very challenging as far as getting patients out of the hospital. If they have effusions after the Fontan, they can have chest tubes that are incessantly draining fluid, inflammatory or chylous or lymphatic fluid. And in those situations, we're quite aggressive at opening things up and seeing if we can get rid of at least some of those collateral vessels to decrease the chest tube output. You see this patient had 2 stents in the pulmonary arteries, a stent in the IVC, and also the fenestration has a stent as well. And there's many Fontan patients that do very well and don't need any of these procedures, but if they do, again, there's that kind of strong relationship between the surgeons and the cath lab to kind of get these patients through the best we can. So again, we described the fenestration before, but again, it's basically a pop-off communication between the Fontan conduit and the atria. Again, you're getting right to left shunting, but you're getting preserved cardiac output in situations where maybe this physiology is not well tolerated with pulmonary artery pressures that are too high, pulmonary vascular resistance that's too high to be compatible with Fontan circulation. So if we get into that situation and the patient does not already have a fenestration, one of the ways that we can put in a fenestration is actually in the cath lab, where with fluoroscopic and echo guidance, we can get either access sometimes from the femoral vein and IVC, but many times actually from a hepatic vein. We get hepatic access. That gives us a nice pathway. That's what you see here. You see we've made a hole through the conduit, through the Fontan conduit into the atrium. So extra cardiac space, which is always a little nerve-wracking. And then the wires in the pulmonary vein, and then we're using a covered stent to make that fenestration. So we don't have to do that very often, but it is a tool that we have in our back pocket if a patient is not tolerating Fontan circulation well. There are late complications that we look for, and something that I'm sure, unfortunately, you'll see here at MHI. Again, even though the Fontane's the best we can do for these patients, it's not normal, and eventually it catches up to people, and they can have effects from that. These are two kind of uh, entities that we see in patients that are having what we call a failing Fontan physiology, where sometimes for reasons that are difficult to understand, or they have higher venous pressures, higher pulmonary vascular resistance, and they can have derangements in their lymphatic drainage, and that can be quite a big problem. And these are two examples of that. So plastic bronchitis, lymphatic leak in the bronchi, and they'll often cough up what we call these caths, and they basically look like the airways when they come out, and they're just this kind of like plastic looking casts. And then the other big entity is protein losing enteropathy, where it's basically the same physiology, but you're losing protein from the stool, and those patients can become quite ill. They can become anosarchic, have abdominal distension, and then become quite ill. Treated with systemic steroids, and sometimes this means the writing's on the wall as far as maybe needing a transplant in the near future. So it can be quite a dire situation. Um, I think lately in the modern era, you know, medical management has been a little more successful with these patients, but previously PLE was kind of thought to be, a sign that you'll need heart transplant in the near future. I would say it's still something you don't want to see, but sometimes we can get these patients through it. Many of them will have atrioventricular valve dysfunction kind of progressively as they age. And again, these are the kind of patients that will transition from our children's hospital, and many of them will come here. Just to switch topics to transcatheter pulmonary valve replacement, which is one of my favorite and hopefully Dr. Gessel's favorite procedures we do here together. This is something that's been really great in the last decade or more as far as more tools that are designed for us. And many patients many types of patients can benefit from these technologies. Here's just some examples. A lot of them have tetralogy of Fallot, which again is pulmonary valve stenosis or severe RVOT obstruction, a VSD, overriding aorta, and a hypertrophied right ventricle. And if we talk about the physiology of that, when patients are first born, it can be quite variable as well. So it can range from not having enough pulmonary blood flow and being quite blue when you're born. If you have severe pulmonary stenosis, don't have enough pulmonary blood flow, that's another patient that may need a BT shunt or an initial palliation for an extra source of pulmonary blood flow until they're big enough to have a surgical repair. On the other hand, maybe there's only moderate pulmonary stenosis and the saturations are in the 80s, or the systemic saturations are tolerable. Patient can go home and eat and do normal baby things for a few months. Then eventually around 6 to 9 months of age, typically maybe 4 to 9 months of age, they'll have a repair. And if it is a patient that has a very dysplastic, very stenotic pulmonary valve, very severe RVOT obstruction, oftentimes they'll end up with this type of repair, which is a transannular patch. So in this picture, the VSD is closed, and then there's a big patch that goes across the pulmonary valve and opens up the right ventricular outflow tract widely open. These patients typically don't have any functional pulmonary valve at that point, so they have free pulmonary valve insufficiency. And young kids tolerate that physiology very, very well. They don't tolerate pulmonary stenosis, severe pulmonary stenosis in the long term, but they tolerate free pulmonary insufficiency very, very well for many years. So they can be completely normal kids early in life. And eventually, what happens in the setting of free pulmonary valve insufficiency is you'll start to get right ventricular dilation and dysfunction, and maybe symptoms. Most common symptoms would be, exercise intolerance or worsening fatigue with activity. And when that happens, based on advanced imaging, we know that they now need a pulmonary valve replacement. Traditionally, that was surgery, which the surgeons would put an RV to PA conduit or a surgical prosthetic pulmonary valve, but now we have, luckily, options in the cath lab. And I'll talk about these valves a little, but there are two main categories: self-expanding valves, which were designed for this situation, and our balloon expandable valves, which were designed for a right ventricle to pulmonary artery conduit. And this also illustrates that many types of patients end up with an RV to PA conduit. In this particular example, it's a aortic stenosis, so a stenotic aortic valve, and that varies significantly in presentation. The most common congenital heart disease is a bicuspid aortic valve, and as you guys know, you can have a well-functioning bicuspid aortic valve that lasts for years and years and decades, and you don't need any intervention, or you can have a very severely stenotic aortic valve where when you're born, you have what we call critical aortic valve stenosis, where you don't have enough systemic blood flow through there to support life. Those patients need an intervention right away. Again, we put them on prostaglandin to keep the duct open, and then almost always the first intervention in those patients is a balloon dilation in the cath lab. If you have enough aortic valve dysfunction, at some point you're going to need something else. And in young patients with mixed aortic stenosis and aortic valve regurgitation, at our center and many centers, the procedure of choice would be the Ross procedure, where the surgeon harvests the patient's own pulmonary valve and puts it in the aortic position, translocates the coronary arteries, and puts this conduit in an RV to PA conduit. And those, again, are patients that can benefit from transcatheter pulmonary valve replacement. The first valve that we had available to us, and the one that across the street we've used the most, is the Melody valve. That was first used 25 years ago, and it was FDA approved in 2010. So been around for 15 years, and this has given the community to collect a lot of data, and it works very well. It's made with a bovine jugular vein, so they harvest cow jugular veins, and those cows are all over the place in the US and other countries, and the minority of they have to go through a lot of veins to find valves that work, and they look like this picture on the upper right. They send those veins to Tijuana, to the Medtronic factory, and they sew it on this valve. They hand sew it on this valve, and it works really, really well in the pulmonary position. Comes in two sizes. Almost always we're using the bigger 22 size. What you see pictured here is the delivery system called the Ensemble system, and I'll show you some examples of using that. But one thing to keep in mind with these patients, and something that I've heard Dr. Gessel comment a few times, is kind of how different every patient can be. And when you're doing these procedures, the balloon expandable valves in particular, you're making a lot of decisions while you're doing angiograms, and a lot of decisions on the fly as far as how best to put these valves in. The main thing, the biggest part of the procedure is preparing the conduit to be able to put the valve in. So just a couple of examples. This is a 22 millimeter RVDPA conduit that's both insufficient and stenotic, so you can see leaking back into the right ventricle. This particular type of conduit is a Hancock, and it has this ring that's very, very strong. It's one of the rings that we're not able to fracture. It's just that ring limits kind of the size of the valve you're going to put in. But here is an example of the Melody going in. You can see there's already a bare metal stent there before we put the Melody in. In the early experience, people would just put the Melody in on its own, and what we found is that stent is quite fragile, it's quite weak, and over time, as the heart beats, you'll get stent fracture. So now we protect that with a bare metal stent. Again, that bare metal stent, not designed for this purpose. They were adult biliary stents, both the Palmaz and the EV3. They work super well for this, to the point where I think now they are FDA approved for this purpose, but they, again, started as stents for a biliary system. But luckily for us, they work quite well for this. And this is just a before and after. You see the insufficient RV to PA conduit in the before, and then a nice competent pulmonary valve now. The Ross procedure that we looked at before is, again, another population that oftentimes benefits from transcatheter pulmonary valve replacement. One thing that's super important that we do every time we do this procedure, as Dr. Gessel knows, is we make sure we know where the coronary arteries are. Because one of the complications of this procedure is compromising the coronary artery as you're expanding this conduit. And you can see that in this picture. The conduit is right in front of the coronary arteries, and it can either be the right or the left. So we have to be very sure that when we go up with with a balloon and the stent that we're not going to compress a coronary artery. There's different ways to test that. I, again, like to use 3D rotation quite a bit in the cath lab across the street, so I use it for this purpose as well. This is how I was trained in San Diego, and it works quite well. So we have a balloon in the conduit, and at the same time we're doing an aortogram, an ascending aorta, and doing this 3D, and now we understand where the conduit is in relation to the coronary artery. So we can spin this around, manipulate it as much as we want on Vitrea, and we can kind of assure ourselves that we're quite far from the coronary arteries before we put stents in. And that's that patient, so tolerated that well. Here's an example of a patient that we bailed on because when we put the balloon up and sized it, it was clear that the Hancock was close and the Hancock conduit was close enough to this coronary artery where we were worried that if we changed the geometry with a stent or a transcatheter valve, we would be compromising this coronary artery. And when we went up on this balloon, we certainly had ST segment changes, and it was obvious that maybe it was not a good idea to proceed. You can see this patient has a DKS anastomosis, so early in life likely had a single ventricle palliation at first, and then down the road was converted to a biventricular palliation. So what you're seeing here is the native ascending aorta connected to their native pulmonary artery, and then the descending aorta. The Edwards is the other balloon expandable valve that we have available to us. If there's any structural interventionalists listening, they'll certainly have a lot more experience with this valve than I do because it was designed for TAVR. But as Dr. Gessel can tell you, it works really, really well for the pulmonary position as well, and it's now FDA approved for that indication as well. We just put it in the other way. The nice thing about this valve is it comes in more sizes, and it comes in a much larger size, up to 26 or 29 millimeters. So the vast majority of the patients that are having balloon expandable valves here, as Dr. Gessel can tell you, are getting this valve, where as opposed to across the street, since our patients are younger and smaller, the vast majority are Melody valves. And this is just an example of that. We have a nice app where if we know what kind of valve the patient had before, we know what the inner diameter is, and if we can fracture the valve, and they even tell us what balloon size to use to make room there, so we can prepare that RVOT or that pulmonary valve for implantation of the Edwards valve, which again works very well for this indication as well. Like I said, there's now some, a good experience worldwide with these valves, enough to give us a sense of the longer-term outcomes. And I won't go through all the words, but in general, the outcomes are very similar to surgery, and as far as longevity of the valves. One thing to keep in mind is endocarditis is a big risk. Much higher incidence than in the normal population or normal native valves. So fairly high risk at about almost 10% at 5 years, with the Melody having a higher risk. And that may not be because of the valve itself, but more because it's going into smaller patients. There may be more likely to have a residual gradient there. So the younger you are, the smaller the valve, the more gradient, the higher chance you'll have endocarditis. So that's obviously a point that we discuss a lot with patients both before and after they have their valve, to be pretty vigilant as far as dental hygiene and other things to try and prevent that. But the risk is there, very similar to surgical RVDPA conduits of the same size, so not very much different than that. There are surgical RVDPA conduits, the Contegra, which is basically the same valve as the Melody. It also comes from a bovine jugular valve, so they have a very similar endocarditis risk. Again, the mortality is very similar to surgery, very 8.9% at 8 years post implantation. So very equivocal to the surgical intervention, but obviously much less invasive. The self-expanding valves, which we talked about, were developed for those patients that had the transannular patch. They're a bit of a different procedure compared to the balloon expandable. Now we have two systems. The Medtronic Harmony valve was FDA approved in 2021. Did have a recall as far as the delivery system, so there was a delay in 2022-ish, but it's been around since 2021, and again is designed for the native right ventricular outflow tract. So as you'll see, a much bigger system. This is the delivery system, and this is self-expanding, so not on a balloon. And as you unsheath it, it gets back to its normal, so to its native size. There's two sizes. This again is made by Medtronic in Tijuana, and also hand sewn onto the stent. So this is polyester polyester fabric, and it's a porcine pericardium valve, and then it's hand sewn. So they have 1,500 hand sewn sutures that are holding the stent and the valve on that material. And one difference between the balloon expandable valves and the self-expandable valves is the candidacy for a lot of the work for these patients is actually done before we get into the cath lab. So a lot of it is dependent on the advanced imaging. So we send the CT scans to both Medtronic and Edwards, and then they basically virtually implant the valve for us and tell us if it's a good fit. So that's what you're seeing here. You're seeing Medtronic's post-processed images. So they even give us these simulated angiograms with the different angles that we'll use in the cath lab when we're doing the procedure. And they'll put the valve in, and they'll give you many pictures of kind of 3D pictures of what the valve would look like and give you a sense of how it will look. And then they also give us this perimeter plot of both different sizes of the valve. And the green here is what you want to see. That means it's well opposed to the RVOT walls. If you see any red, it means that it's not opposed to the walls. So it gives us a really nice sense of how good of a candidate these patients are for the procedure. And this is just what it looks like on fluoroscopy. So this was a patient, again, with a native RVOT with free pulmonary valve insufficiency. Again, they do very well with that early in life, but eventually, and timing varies quite a bit, the right ventricle becomes dilated. We look for an indexed volume of about 140-ish or so when we start to think that they need a valve, or symptoms or RV dysfunction. And now you see on the bottom, this is post Harmony valve implantation. You see a nice competent valve with a pretty large stent there. This has only been around since 2021, so we really only have early outcomes, but obviously the outcomes in that group have been good. The vast majority of the patients are free from pulmonary regurgitation or pulmonary stenosis. Endocarditis does happen. I had one patient already across the street that had endocarditis. I'm sure maybe Dr. Gessel's had some as well. It was a teenager that was unfortunately doing some self-harm cutting behavior, and she did have endocarditis. We were able to treat it, and she didn't need her valve explanted. We were to keep the valve, and she's doing very well now, but we did have endocarditis. It should be lower rate than the balloon expandable valves because they're much bigger and much less likely to have pulmonary stenosis, but still higher than a normal valve. So the other system we have is the Edwards Altera. So that's using the same S3 valves that we just looked at, so the ones that were designed for TAVR. But it's basically the Harmony, but in 2 steps. So there's a pre-stent that you put in, and then you put the valve in after. So a little bit of a different system, but same concept. We also use advanced imaging. Again, we send these to Edwards, and they do a lot, like I said, a lot of the prep work for us, tell us if it's a good candidate or not. And this is an example of what that looks like. So again, just a pre-stent and with that same Edwards valve inside there. And again, good outcomes with arrhythmias being one of the things to look out for. Because those stents are sticking into the RVOT, it's not uncommon that they have ventricular ectopy or runs of VTAC and need to be treated with a beta blocker, typically only for a few months, and then it goes away. One last pathology to talk about, coarctation, something that we see commonly across the street and potentially here. It's 5 to 8% of congenital heart disease, and it can have a very variable presentation. Some babies are born with coarctation, and it's severe enough where they need prostaglandin right away to maintain systemic blood flow. Others are not severe, are not so severe, and can develop a lot of collateral vessels and present at any time in life, even adolescents, teenagers, adults, and they can undergo surgery for repair, and or we can put a stent again uh, with a variety of stents. This is just an example of again a 3D. It shows us post-coarctation repair. You can, in about 10 to 15% at our institution, patients will need some kind of reintervention, and that's what you see here. Develop the recortation, and we can use our 3D overlay. So we use that same 3D spin. We can use it as a roadmap, as one more piece of information as far as if we're in the right place, and then we can put a stent and open that up. Just wanted to show this example because this is a newborn baby with a connective tissue disease and a very unusual, very tortuous aorta, who unfortunately developed significant obstruction. You can see this is a good catheter, of course, to show fellows and quiz them on because it's really weird. Very tortuous aorta. And unfortunately, this baby develops stenosis or obstruction at multiple levels as the child was growing. Baby tested negative for all known connective tissue diseases, but certainly had some unknown connective tissue disease. He underwent surgery, and as expected, the tissue was very friable and very difficult for the surgeons to work on, but got him out of the hospital, got him some growth, and he developed a recortation there. We were able to take him to the cath lab and open that with, again, a stent not designed for this, but works very well, a covered Gore Viabon VBX stent. And this baby, despite being only 8 months old, because of the connective tissue disease, the aorta is actually quite big. The stent, we got to 16 millimeters. And this was about a year afterwards. To kind of bring it all back together, this is now a stent that was purposely designed for us that just came out last year, FDA approved, and it goes through a 4 French sheath, so we can use it for little babies. We can put it in at an initial diameter of 6 or 8 millimeters, and then we can expand it up to 24 millimeters, or actually even bigger. So hopefully we could stent a baby maybe with a recortation in infancy, and then as that baby grows to become a child and an adult, they can keep that stent, and we can make it big enough for adult size. That's an example of that particular stent in a 10-month-old with that's 10 kilos. So that's really all the pathology and examples of procedures in the cath lab, and I just wanted to wrap it up by, talking again about how important it is for these patients to have somewhere to go, because as we said, the survival is much, much better than it was decades ago. And as you can see by these pictures, these patients can be quite complicated with a lot of moving parts, and they can fall through the cracks. 20 people in their 20s, even with heart disease, they don't think about their heart as much as they should, even with severe heart disease, and they can kind of go away and come back and have a lot of issues to take care of. So this document comes out every 10 years, and it is kind of a guide for ACHD, and it goes through. It's nice because it goes through a lot of the diseases in detail. But this slide really demonstrates how complex it is and what is required for a center to take care of these patients. And here, there's been a lot of people that have laid a nice groundwork, a nice foundation, like Dr. Gornick and some of my partners across the street. Of course, Dr. Sun and Dr. Moga work together. So there's that foundation here. And as you can see by this list, across the street and here, we have a lot of these things already in place. And we have a really the potential to kind of grow a really nice program because we have all this stuff. What we really need going forward is more people. So now this first line, ACHD board eligible or board certified cardiologists, that's a big part of modern ACHD programs. Now it's its own 2-year fellowship. So a lot of these people are really dedicating themselves to that field. So it may be someone that did med peds residency, so a 4-year residency, either pediatric or adult cardiology, so another 3 years, so 7 years, and then 2 extra years of ACHD. So a lot of training going into this, and it's because of how complex these patients are, and the more they survive. The longer they survive, the more we learn, the more complex they are, and there's just a lot of moving parts to keep track of. So I think here we have the potential, because of what Dr. Gessel mentioned, our hospitals are connected. We're in a medium, size metro with a lot of people. We have a really nice opportunity to grow a really nice ACHD program, but we need people, dedicated to that. And there's more programs than there are people. So, there's not as there's ACHD fellows coming out, but there's a lot of places like us that are looking for them. And that's all I had today. Happy to take any questions.
Thank you, Rod. That's a complex overview, and I know we ran a little bit over time, but I think that's okay. And Chuck is here too. Any burning questions right now? Maybe we can still do that. Thanks for staying, by the way.
That's sorry. Some people are
to me. Check.
I wasn't, first of all, you did a really nice job going through a lot of you did a very nice job going through a lot of complicated initial surgeries and such. And I just want to add a plug for the adult congenital program in saying that you realize that as these children survive, there are actually more adults with congenital heart disease than new children being born with congenital heart disease.
Absolutely.
Which is a real challenge for us in our program because, as you can see, these patients have recurrent needs for surgery, recurrent needs for intervention. They need valves. My area of expertise, cardiac electrophysiology, they have lots of arrhythmias and lots of pacemakers, lots of defibrillators. So this is really a lower volume group of patients, but high users of lots of different techniques and technology. And it only grows, it's only growing. So thank you very much for an excellent morning presentation.
My pleasure. Very good points.
Hopefully this quick question. I thought this was amazing too, and as a fellow, it's very enlightening to see all of this. Just out of curiosity, how are patients transitioned from pediatric to adult cardiology like currently? And I'm sure it's very nuanced based on what's going on, but is there an age that you stop seeing patients generally?
That's a great question, and it's something that's evolved over the years. We don't have a set in stone age where we're transferring patients. Typically, it works out to kind of early to mid-20s. A lot of times, I find with my families that I follow is to find a practical time to transfer them, and a lot of times that's college or after college, because that's when the patients are, moving out of their mom's basement or the dorms, or finding their own place to live, they're paying taxes, doing adult type stuff. They don't need to come to the clinic with, where's Waldo on the wall anymore. And that's a really nice practical time because the patients, decide if they want to stick in the area or move somewhere with palm trees, or, and we can help them find a spot. We do have staff now in our clinic, administrative assistants that help us transfer patients to either here or Mayo or other centers, just depending on where, what their particular congenital heart disease is and where they'll end up.
Any other questions? Yeah, I think from my standpoint, I mean, I wasn't trained in congenital, and I think the connection is growing, right? Because the young adults are coming, they have like 4, 5, 6, whatever surgeries. And when they hear that there is an Altera valve, a Sapien valve, a Harmony valve, if there's anything that you can do in a cath lab, they always are, excited about that. Some are very complex where you say, well, it's kind of a borderline case, but they always want to go for it because that's the one thing, it takes 2 or 3 hours next day home versus another 2 weeks in the hospital or, some sort of complication. But without that collaboration, I mean, I would say I wouldn't do it, right? So if Children's wasn't here, if Rod wasn't here, if anybody like that wouldn't here, I would say, I'm not going to do that. That's too complex. We need that expertise. We need to work together. I have that valve expertise of the newer valves, but he has the physiological and technical expertise, right? It only works that way. And it's a very cool example, actually, how collaborations can work. To the point that I just want to say at the end, the foundation was able to get a huge grant for a biomarker study that we're going to do on these newer valves, Harmony, Sapien, and Altera. And it's the first time that we do kind of a biomarker study on longevity and degenerative processes halt on these valves with like 10 centers in the United States. So even on that level, these collaborations are really, fantastic. And we're really, really glad to have those things going on. So thanks.
Thank you.
We're going to keep working on that.
Yeah, yeah.